Does it seem to you that everyone has an allergy these days? Well, it's not just a feeling. There's been a massive bloom in allergies globally. But why? Is it really because we've gone overboard with hygiene, or is it something else? And what can we do to lower our risk of developing allergies or manage symptoms if it's already too late? Whether you have hay fever, which affects more than double the amount of people than it did in the 70s, or you're allergic to peanuts or eggs, or even your fluffy pet, there are science-backed ways to make your life easier and less stressful. And today we meet the man with the answers. I'm Dr. Karan, an NHS surgeon, and in this podcast, we cut through the BS of modern health advice and tackle the biggest issues in science and medicine. Professor Adam Fox is a professor in pediatric allergy, and this episode we touch on the science of allergy response and why it happens, a treatment option that's turned the allergy world upside down, why having eczema makes you more vulnerable to developing allergies, the role of the gut microbiome, and why allergy tests are often a waste of time, and much more. Enjoy. Adam, thank you so much for joining me today, and this is a topic that I've really been wanting to get to the bottom of, because when I think back to when I was in school almost 30 years ago, and I think about kids in my school who had allergies to peanuts or whatever it was, it didn't seem to be a big thing. There was maybe the one kid who had a peanut allergy. And nowadays, it seems to be far, far more. I mean, 10% of people in the UK have some sort of allergy. Why are we seeing such a rise in allergies all across the world, particularly in developed countries and urbanized environments over the last few decades?
It's a great question, and it's been a really profound change. So there's a lovely story about the origins of hay fever, and that goes back to a pediatrician called Bostock. He was based in Manchester, and he had hay fever, and he sort of clocked himself that he was getting these seasonal symptoms that coincided with when the pollen count was high. So he thought it would be a good idea to write it up in the Lancet, but in order to do that, you needed a few more cases. It took him 9 years to find another 20 or so cases to write up. Now, if you go into any room of UK adults these days, and I'll often do this when I give lectures and ask people with hay fever to put their hands up, it's 25% of the population. So in 200 years, we've seen this vast change in a pattern of disease that clearly we can't be putting down to genetics, because genetics do not change that quickly. And then you look at other things like asthma and eczema, which were unusual 40, 50 years ago and have become increasingly more common. But the example you cited, food allergy. Now, I had a very similar experience when I was at school. I'd love to say it was 30 years ago, it was a little longer ago. But there was one kid in the school with a peanut allergy. And it's a horrible story. He died of a fatal anaphylaxis after doing a year off. I think he was in Southeast Asia, and on his travels home, he having been safe the whole year, he accidentally had some peanut and died as a consequence. My son went to the same school that I went to, 30 years behind me, and I know innumerable numbers of his classmates professionally, because there's so many of them with allergies. And in fact, just last week, there was a new report from Imperial College that demonstrated that over the course of the last 20 years or so, we've seen a marked increase in the amount of food allergy that's around, and it now affects 5% of UK children. Thankfully, the numbers diminish as you get older and older, because lots of people outgrow typically allergies to things like milk and egg. But food allergy is not an insignificant problem even in the adult population now. It's become a major health issue. The original question is, well, why is this happening? And traditionally, the answer was always, well, it's that we're too clean. And what we often refer to as the clean child hypothesis, or the hygiene hypothesis. So this idea that as our culture and lifestyle has become cleaner and our children get less infections early on and don't have to contend with typhoid and diphtheria, that somehow our immune systems aren't kept occupied enough by important things and consequently find inappropriate things to react to, and hence you get a rise in allergic disease. The theory has got huge holes in it. It's actually really based on findings in the 1980s, where epidemiologists noticed that the oldest child in the family seemed to be more likely to have hay fever compared to younger children. So the idea being is that the youngest child in the family doesn't have older siblings bringing all germs and bugs back from other nursery schools and gets less infections, so is more likely to develop allergy, whereas the younger children have got older siblings who are bringing germs and bugs back from nursery, and as a consequence, their immune system is more mature and develops quicker because it has to, and as a result, they don't get allergies. Nice idea, except that that finding isn't consistent through studies. And there are plenty of studies that don't show that the oldest child has got less allergies than the younger children. And also, you just have to look around the world about where food allergies and other allergic disease are more common. And it doesn't match things like infant mortality rates. If the hygiene hypothesis was right, why isn't Switzerland, which has got the lowest rates of infant mortality, leading the world in allergies? It's not even close to being up there. In fact, when you look at who's got the most allergies, it's the UK and Australia and Canada and New Zealand and the US. It's clearly not geography, but you can't help but think that there's something cultural going on here, because it's very similar westernized cultures that seem to have the highest rates of allergies. And then, of course, what we've heard much more about over the last 10 or 15 years is our understanding of the gut microbiome. So the idea that the bacteria that colonize our guts have a really important pivotal role to play in the way that our bodies relate to the outside world and how our immune systems develop that relationship. And I think there's now far more traction behind this idea that something has changed around our gut bacteria over the last 20 or 30 years because of cultural and lifestyle reasons. And there's loads of them. Babies being born in hospitals, whereas they used to be born at home, changes in weaning practice, use of antibiotics, ultra-processed food. There's 100 different things that will influence that. And that it's probably that is influencing why people who have got an allergic predisposition, and there is a big genetic component to this, are more likely to get allergic disease than maybe they were 10 or 20 years ago.
I think, yeah, that's very comprehensive. And that's something, the gut microbiome, I want to touch on a bit later. But first of all, just digging into that word allergy and allergies. We commonly think of food allergies like peanut or shellfish, but also other things, inanimate objects, can also cause allergic reactions. What is the biological definition of an allergy? What does it happen on the underlying scientific basis?
So essentially what's happening is it's an inappropriate immune response. So our immune system will usually think in one of two ways. It either recognizes something as harmless, like food, or for most people, peanuts or house dust mite or grass pollen, and it ignores it. And it just does nothing. It looks at it and decides, not interested, not going to do anything about it. That's what we refer to as tolerance. Or the other response our immune system can make is it can decide that it's something dangerous and it needs to kill it. So if it sees a germ, a bacteria, a virus, some sort of bug, and it will often be hardwired to recognize these things, or it learns through an adaptive immune response. And when it sees it, it will take measures to kill it. Now, erroneously, often people refer to allergy as being when your body gets it wrong and responds as though it's something dangerous when it's not. But in fact, allergy is a third distinct type of immune response. It's not tolerance. It's not ignoring something. It's not treating it as though it's a virus or a bacteria. It's something different, and it's unhelpful. It doesn't serve a useful biological purpose, and it's potentially harmful to the individual who has the allergic response. So if you dig into the Latin origins of where the words come from, this idea of atopy, which is what the name we give to people who have allergic responses, it means other response. And it was recognized a couple of hundred years ago. There was a guy called von Perke who noticed this response happening, and he came up with this term allergy to describe people who had these inappropriate responses to things. What's happening in your immune system is that when it recognizes something as a problem that it wants to respond to in an allergic way, your immune system releases a load of chemicals, but the really important one is histamine. And that's why we use antihistamines when we have allergic reactions. And when your body releases a load of histamines, those histamines will have certain effects on the body. The sort of not so important ones are that it makes you itchy and it will give you bumps in the skin, hives or urticaria. It will make you feel hot. But the worrying ones are the effect that it will have on your breathing systems, on your lungs. It can tighten up your airways, making it harder to breathe. And it can have an effect on your blood circulation, so it can drop your blood pressure. So if you have a huge release of histamine, which would happen when, for example, you had an anaphylaxis, which is a really severe life-threatening allergic reaction, that worrying things that happen are that your airway tightens up and your blood pressure drops. And that together can be catastrophic.
And you've mentioned there the extreme of an allergy, which is an anaphylactic reaction, a really severe life-threatening allergy. But some people have mild allergies, and then there's a whole spectrum of allergies where someone can be landing in between a mild, where they just maybe get some skin irritation, to that extreme life-threatening. potentially fatal allergy. Why is there a spectrum of allergies? I mean, presumably, if someone did trigger the immune system in a way that it released histamine, it should be somewhat of a standardized response you would assume across all humans. So why do different allergies, or even the same allergy, trigger such a marked response, a different response in different human beings?
I think it's because it's a really complex response and loads of different factors will influence it. So, for example, where you are exposed to the thing that you're allergic to. So, if I rub a cream that I'm allergic to onto my skin, I'll probably just get a local response and that's it. Whereas if I'm injected with a medication into my vein that I'm allergic to, or I'm stung by an insect that I'm allergic to, then that level of exposure is much more likely to cause a bigger response. And the more histamine release and the more it sort of triggers a sort of cascade that then spreads quickly, then the more likely you are to have a bad reaction. But then there's so many other factors that will influence it. So, for example, we see in kids with food allergy that when they're under the weather and unwell with a bit of a sniffle and they have an allergic reaction, they're much more sensitive and more likely to have severe reactions. If they've been exercising, they're more likely to have a bad reaction. If they've been drinking alcohol, if it's the time of the month, there's a multitude of different things that will influence that. And when you get into these really complex mathematical models to try and work out how much contribution of how bad a reaction is from the amount of food that you ate or what form it was in or whether you're unwell or whether you exercised, all of that still drops out for one really, really big factor. It's just unpredictable. Now, it's probably individual factors that we just don't understand, why certain individuals can be exposed to a small amount of peanut and get a little bit of a tingle, and others will have a catastrophic reaction, or that the same individual on different occasions can have a very similar exposure and very different levels of response. So I think the bottom line for that question is we don't really understand. But when it comes to food allergies in particular, but also venom allergies, latex allergies, they are unpredictable. And this is what makes it such a challenging condition to live with. Because we can say to somebody, look, if you've got a food allergy, you are still far more likely to die in a car accident than you are to die of your food allergy. In fact, you're more likely to be murdered and you're more likely to die in a fire. Your chance of dying from your food allergy is tiny. But the problem is we don't know which of the huge number of people with food allergies is going to have that catastrophic reaction. So essentially, you end up having to treat everybody with food allergy broadly as though you might be the worst case scenario. And that means that there's a huge amount of anxiety attached to it.
I mean, assuming someone has a peanut allergy, for example, and perhaps in this case, it's somewhat of a moderate reaction. Now, this person doesn't naturally have to go around their entire lives fearing every single thing they touch, or maybe they might. What about in specific cases in restaurants or even on food packets where they might say, this is peanut free, but has been made in a factory that also make some peanut products or may contain traces of XYZ according to whatever allergy they had. How worried does someone have to be when they see a may contain traces of or has been produced in a factory that also produces your allergy?
I think the first question I always get asked after we diagnose somebody with a food allergy is, how bad is it? How severe is it? Is it a bad peanut allergy? Is it a mild peanut allergy? That's, of course, what people want to know, because they want to know, how worried do I need to be about this? How careful am I going to have to be? And unfortunately, we have to give them a really unsatisfactory answer, which is that we're just not able to classify people like that. If you have a genuine food allergy, then chances are you'll be absolutely fine. The overwhelming majority of reactions, if you have them, will be mild. There's a good chance on any given day you'll be able to tolerate a small amount. You wouldn't react at all. But unfortunately, unpredictably, you might have a bad reaction, and we can't account for that. So essentially, what it comes down to is you have to start approaching life generally, which I think we do for all other aspects of our life anyway, through risk assessment. So for most patients with for want of a better word, a regular peanut allergy. So somebody who hasn't got a history of reacting to unusually small amounts, which is a very, very small number of people. You do get some individuals who are exquisitely sensitive to very small amounts, and they do have to be a bit more careful. But for the overwhelming majority of people with food allergies, when they read those food labels, they have to take a view. They have to use risk assessment. And what that means in practice is thinking, okay, am I well today? Because if I'm well, I'm not overly sensitive, whereas if I'm under the weather, I've got a cold, I'll react to a smaller amount than I might otherwise do. So if I'm well, I've got my medication with me, and I'm somewhere that if I were to have a reaction and needed help, I could call for it and expect it to come in a sensible time frame, then it's not unreasonable to eat things that say may contain, because the risk is actually very small. Whereas if you're under the weather and you are more sensitive than usual, or you've left your medication at home, or it's the doctor's strike on that day, or you're visiting friends in rural Norfolk and you've got no chance of an ambulance getting to you in any sort of decent time frame, then you're going to have to be a little bit more careful. What we don't say is these blanket avoidances of, avoid everything that says may contain, because that's overly restrictive for all but a very, very small minority of people. And I'm a huge advocate of my patients eating in restaurants and going on holidays and very much living life to the full. And my job as their allergy doctor is to give them the confidence and, where possible, offer them the treatments available to ensure that they can do all of that. Because sometimes what I see happening in families where kids have got particularly multiple food allergies, is the way that the family is managing that is so restrictive that that's become the problem rather than the actual underlying food allergy.
As you mentioned before, there are a lot of people who maybe as a child have some sort of allergy and they grow out of it. Now, can the reverse happen when the allergy gets worse over time?
So there's an urban myth, and it's one I always like talking about because it's the one that frustrates me the most, particularly because I've heard it on the TV a number of times from people that really ought to know better. This idea that each time you react, it gets worse, and it's simply not true. Each reaction that you have will depend on the circumstances of that reaction, plus that unpredictability element that's in there as well. But this idea that if you've had a mild reaction, the next one will be moderate, and then the next one will be more severe, and the next one's going to be curtains, is simply not true. If you've had bad reactions previously, you are more likely to have a bad reaction in the future. But it causes, as you can imagine, an enormous amount of anxiety that if you believe each time it's getting worse, if you have quite a bad one, you're going to think, that's it. I've had my 2 strikes. The next one, I'm in, deathly trouble. And then that reaction might happen and they'll get a little bit of a swollen lip and that will be it. We do sometimes see people who aren't allergic to things develop allergies in later life. So children with allergies to things like milk and egg and wheat and soy normally outgrow it in early childhood. Some of them hang on to it, but not many. Whereas you get adults who have spent their whole lives enjoying fish and shellfish without any problem, suddenly out the blue having anaphylaxis. So unfortunately, allergy is something that you sometimes just can't account for. But that doesn't mean that we should all be carrying adrenaline around with us and EpiPens. It doesn't mean that we should all be worrying about it overly, because these things thankfully are still extremely rare.
But what is the process by which someone who's got an allergy and their immune system is sensitized towards that, external allergen triggering some immune response and the histamine release, and then at some point in their early life, then suddenly their immune system almost deleting the record of that allergy and being like, okay, we're no longer allergic? What is the underlying process there?
Yeah, that's a great question. And I think there's a Nobel Prize in it for somebody, because we've known through observation that if you've got a milk or an egg allergy and you're little, that you've got a really, really good chance of outgrowing it, because that's just what happens. But what is the process by that, how that happens, and why is that not happening for kids who have got peanut allergies or sesame or tree nut allergies, where only a tiny minority outgrow it, but some of them do? Or even a better question still, why are there some children who you can do an allergy test on, a blood test or a skin test, and they clearly are positive for the allergic antibodies for a particular food or substance, but they don't react to it? So there is a level of complexity that's going on sort of underneath what we're able to superficially see, that means that our understanding is still absolutely in its infancy. And it would be fantastic, wouldn't it, to be able to diagnose somebody with allergies reliably and then say, look, we know this is going to go away, or we know this is not going to go away, when in fact the reality, because we can measure something that's telling us that that's going to happen, when in fact in reality all we do is we just say, well, look, statistically we know people with your profile, you've got X chance. AI is helpful here, machine learning, better understanding of what's happened previously to enormous numbers of people who have had similar allergy tests with similar allergy profiles. So we'll get better at that prediction. But that's all we're doing. We're just predicting it. We're not basing it on a solid science that says this is what's going to happen to your allergy. I suspect we'll get there. There are already tests. There's a very, very expensive special allergy test for peanut available in the US. We looked at bringing it over here, but it was so insanely expensive, it just wasn't going to be worth it. That could broadly tell you whether you're at risk of a bad reaction or not such a bad reaction. But as is always the way with early technologies, there was a huge overlap between the two groups. So it didn't really say you're definitely going to have a bad reaction or you definitely won't have a bad reaction. It was more, you're more likely than the next guy to have a bad reaction, or less likely than the next kid with peanut allergy. And that's not enormously helpful. It doesn't really change the way that you manage your allergies.
So if we rewind back to most people's early lives in their early childhood, and that's often seen as this sort of seeding ground where, the kind of soil is fertile and things happen for better or worse, partly because of the environment, the immune system is still developing, the microbiome, as we're continuing to appreciate, is also playing out its own sort of simulations as to how it's going to interact with the immune system and also, develop a risk or whatever of future diseases. What is it specifically about the microbiome that increases or worsens our risk of not only autoimmune diseases, but allergies as well? Because I've seen countless studies, which granted have some flaws, which suggest various factors which can increase or decrease the risk of an allergy. For example, just being in an urban versus non-urban environment, being, like you said before, maybe the first child versus the third child, or having a pet versus not having a pet. All of these seem to have some correlation, maybe not causation, but some correlation with the allergy risk. So what is it about the microbiome that influences this so much?
I think you're absolutely right. It's a nudge in one direction or the other. And if you look at the studies, and this has been going on for some time, you can tell a difference between the microbiomes. In fact, not just the gut microbiomes, but the skin microbiomes, the nasal microbiomes of people who have got significant allergic disease and people who haven't. And that raises an obvious sort of chicken and egg question. Well, is the reason why the nasal microbiome of somebody with shocking hay fever is different to somebody who doesn't have hay fever at all? Is the difference in the microbiome the reason they got the hay fever, or do they have different microbiomes because they've got bad hay fever? And I don't think we really know that, but there's a lot of interest in the early origins of allergic disease. And in fact, for me, it's been a lot of personal interest. It's what I did my degree dissertation a lifetime ago on. It was all about understanding the early origins of peanut allergy and what was it about certain individuals that meant that they got a peanut allergy where a very similar child with very similar predisposing factors didn't. Now, in fact, this was sort of a little bit pre-microbiome days, and it wasn't something we were talking about a lot. I suspect if that was in the mix, it would be another factor on top of that nudged you towards an allergic sort of tendency or not an allergic tendency. But I think one of the risks when we talk about microbiomes is that we forget about genetics a little bit, and don't forget there is a huge underlying genetic tendency. And if you've got parents with allergic disease and you inherit that, you are much more likely to get allergies than somebody who doesn't have that allergic tendency, microbiome or not, whatever's happening in your microbiome. But I think it's probably less about which bugs you've got and how many of them, which I think we can sometimes be a bit overly focused on, are more about the type of chemicals that those bugs are producing, and different bugs will produce different chemicals, and they'll create a different environment in which our immune system is sitting. And the nature of that environment that the immune system is sitting in becomes a really important factor as to whether an allergic response develops or it doesn't. But in fact, when it comes to things like food allergy, I think that there's more interesting stuff to be said at the moment about the genetics and other aspects that are contributing to food allergy developing than for the moment what we know about microbiome. And the reason I say that is because it's research that has led to things that we can do to then reduce the risk of allergies developing. And we're just not at that point where we're able to say that we've got really good studies of microbiome that demonstrate that if you take probiotics, for example, when you're very little, it will stop you from being as likely to become allergic. And in fact, we did this. I was involved in a big study a number of years ago where we got a huge number of milk allergic kids who weren't able to breastfeed for whatever reason. They needed to go on these special broken down formulas that babies with milk allergies go onto. So we randomized them to either go onto a regular broken down formula or one that had pre and probiotics that had been shown to influence in what we believe to be a positive way, i.e. lots of lactobacilli and bifidobacteria in that formula for those randomly selected half of those kids with milk allergy. And the plan was we'd follow them up and hopefully find that the kids who had the probiotics outgrew their milk allergy quicker, were less likely to get other allergies, less likely to get troublesome eczema and asthma. Didn't really find a difference at all. So, whilst we can detect the differences are there, the interventions aren't quite there that make a difference as yet. Although, interestingly, people are doing studies of desensitization. I'm sure we're going to come on to talk about that as a treatment for food allergy, and seem to be finding that when you do that alongside friendly bacteria, probiotics, it seems to work a little bit better. So I think there's a story to unfold around allergy prevention and probiotics. We're not there yet. Where we know much more is about the idea that if you introduce allergenic foods very early into the infant weaning diet, that seems to reduce the likelihood of those allergies developing. Not eliminate the risk, but very, very significantly, materially reduce the risk. And that's hugely exciting. This idea that we can identify kids who are at high risk of developing allergy and do something that's going to make them less likely to be allergic. For me, through my career, where we've gone from sort of being only able to sort of diagnose allergies when they happen, but do nothing to prevent them, to now being able to give solid evidence-based advice that we know is going to markedly reduce the risk. That's fantastic. But there's a whole backstory to that.
So we know that obviously the microbiome has a role to play, and we're still trying to figure out what exactly that role is and how it sort of entrains the immune system. We also know that genetics is a huge component. How big a role does environment in that early childhood play? And particularly now with climate change, is that a contributing factor to the rise of these atopic diseases that we're seeing as well?
So I think environment is hugely important, but I think it's probably more about the microenvironment around that child rather than sort of the big thing. Climate change is important in allergy because, it's having a big impact on pollen. So we're seeing more hay fever, we're seeing longer seasons, higher peaks, wider geographical spread of allergens that previously didn't affect certain areas. So definitely there's a big role there. But in terms of sort of the environment in that sort of more of the microcosm of the infant's sort of, home environment, hugely important, because if you look at kids around the world and you look at what they become allergic to, it's clearly very much influenced by what's being eaten in the family home. So if you get kids in Australia, North America, where peanut butter is a big thing, after milk and egg, the most common food allergy kids who get allergies get is peanut. But if you go to the Middle East, where everybody's eating hummus and people aren't so big on peanuts, it's sesame allergy. If you go to Singapore, one of the most common food allergens is bird's nest. In India, chickpea is a common allergen. All of these things are very much influenced by what's around the child. So what we now understand is that the key risk factor for developing food allergy is having eczema. Now, eczema, we now understand, is genetically programmed. If you haven't got enough of the sticky stuff that sticks the skin cells in your skin barrier tightly together, and you get a leaky skin barrier, and you get eczema when you're little, and the worse your eczema is and the earlier your eczema starts, the more likely this is to happen. If other people in your home environment are eating peanut butter or hummus that's got sesame in it, and then they're kissing and touching that infant, so that the immune system in that infant's angry eczematous skin is seeing for the first time, because those infants who are exclusively breastfed or formula fed have never seen those proteins before. If they're seeing those proteins for the first time through their leaky skin barrier, that's when they're most likely to see that protein and make a mistake about what they should think about it and develop inappropriate immune responses, underpinned by their allergic tendency that they've inherited genetically and by probably important microbiome factors as well. So if you get a load of small children with significant eczema and put them in homes where other people, older siblings, are eating peanut butter and they're kissing and touching that baby, a number of them, depending on the different risk factors they have, how bad their eczema was, how much exposure to the peanut there was, those other microbiome things, those kids have a high likelihood of then developing a peanut allergy. So that first exposure of the immune system is happening through an inappropriate route, and that's where the problem is. We always used to wonder, what's going on with peanut allergy? We know your immune system can only react to stuff it's seen before. So how are these babies reacting the first time they've ever eaten peanut, which is what you normally see? Usually it's the first, sometimes the second or third time, but usually the first. So the original theory going back 20, 30 years is it must be in utero. It must be mums who are pregnant eating things and then the baby becoming allergic in utero. But then when they're born and you do blood tests, even on the cord blood, literally the second they're born, there is no sign of any allergic antibodies. They are not allergic when they're born. Allergy develops post being born. So then the theory was, well, it must be through the breast milk. But we've got armies of patients who have got food allergy who were never breastfed. So that doesn't work either. It was only after sort of going through all of that that it became apparent that it was actually this skin contact. And then it all started to make sense why the eczema was so important. And in fact, we now know that if you very aggressively treat eczema from very early on, you can reduce the likelihood of food allergy developing. But treating eczema is really hard in small babies. And you also need parents to engage with using lots of topical steroids, which for good reason they can be very nervous about doing. So it's not a great strategy for prevention. But what has shown huge benefit is the idea of saying, well, wait a minute. If the risk is that your immune system in your skin sees peanut or sesame or egg before the gut immune system has seen it and knows because it sees it in the gut that it's food, we've got a bit of a race against time here. So what if we introduce those foods to the gut earlier so that there's less of a window for the skin immune system to see those foods and make a bad decision? And in fact, when those studies were carried out, they showed exactly that. The earlier you got going with those allergenic foods into the weaning diet of kids at high risk of getting allergy, the less likely they were to get allergy. So now we have public health advice that's gone across the world that is saying that, if do not delay the introduction of allergenic foods. 15 years ago, we were telling mums, don't give your infant peanut. And it was bad advice. In fact, the advice should have been the opposite, which is the second you start giving them solids, pile in with all of these common allergenic foods, because the quicker they're eating them, the quicker you close the door on the potential for those allergies to develop.
In that similar way, in that similar vein where you try to introduce these, allergenic foods like peanut, is that across the board with milk, eggs, and other things as well? Would you advise for, parents with young children?
Not really. Frustratingly, not all allergens play by the same rule. And I think the big outlier is milk. And that's because, of course, exposures to milk happen in a very, very different way. So there's a lot of ways that it's different. So, for example, it's very common for infants to be given milk, cow's milk protein from right at the get-go in the form of formula. A tiny amount of cow's milk protein can also get through mum's breast milk. So exposure is very different. And in fact, we don't really have a good understanding of advice to minimize the risk of that. And I suspect that some of the research is limited by the fact that thankfully most people outgrow their milk allergy. So it's an unpleasant condition as it is. And actually, what I think a lot of people don't realize, the most common cause of fatal anaphylaxis in younger children is actually milk. It's not peanut. Everyone talks about peanut allergy, and nut allergy is the most common cause of severe reactions in older children and adults, but in younger kids, actually milk is a more important allergen in that context. But our understanding of how to prevent that is limited. We know, for example, that if after a baby is born and it's an infant who is exclusively breastfed, but for the first 2 or 3 days, they just get given a couple of top-up formula feeds, that seems to be a risk. That sort of small, potentially sensitizing dose that isn't then followed up by regular exposure in the form of formula, that seems to be a particular risk factor. And many times in my clinic, the mums will sit down in that chair in the consult and they'll say, so I exclusively breastfed my baby, but they did have a couple of top-up feeds on the maternity unit after birth because I'd had a cesarean or this reason or that reason. And I sort of know what they're about to say. And the next line will be, and then at 5 months, we gave our baby their first top-up formula, and they had an immediate reaction to it. So we know that there are some things that seem to be a risk factor. And if you've had a cesarean, that seems to compound that risk factor, probably something about the microbiome in there as well. But strategies to reduce the risk of milk allergy, we've not got great advice to offer at the moment. But when it comes to allergens like peanuts and tree nuts and sesame and egg, which are some of the key important other ones, that's where there seems to be stronger evidence about early introduction. And you'll get different approaches in different countries. So, for example, in Europe and the US, they recommend exclusive breastfeeding, but introduction of solid foods from 17 weeks so that you can sort of get on and introduce those allergenic foods quite a bit earlier. The UK advice is more conservative. It's exclusive breastfeeding for 6 months, then don't delay the introduction of allergenic foods. But it does mention that for high-risk kids, and what they mean by that is kids where there's significant eczema or already been an allergic reaction to egg as an early weaning food, for example, then there might be a place for earlier introduction of allergenic foods. And that's where it says sort of, pick this up with your doctor to discuss the individual risks and benefits of introducing foods earlier. And we have, if I'm lucky enough to have that conversation as early as that with a mum, we're able to talk about the importance of continuing breastfeeding whilst introducing allergenic foods, and getting on with that quite early can markedly reduce the risk of those allergies developing.
It's really funny because, like you were saying, years ago, the advice that I guess doctors were giving was in contrast to what we're giving now about this because of the new data that we have. And I just wonder, given the amounts of allergies that people have, they're born with, they develop at any point in their lives, why would it not worth anyone doing an allergy test? I know there can be a wide discrepancy in the quality of these online tests, or even, if you go somewhere physically and do a test, but why should or shouldn't someone do an allergy test if they're asymptomatic and are self-diagnosed as not having any obvious allergies?
It's a great question, and over the last 20 years, I have been approached innumerable times by people saying, "I've got a great idea. We're going to get a bus that we park outside the maternity units or Tesco's or wherever, and we're going to just test everybody that comes out." And it always goes the same way with us, sort of saying, "You just don't understand allergy testing." As a screening test, it would be an absolute disaster. So allergy tests are, very central to my professional existence, but they're very challenging tests because much as we would love them to be tests that just say, yes, you're allergic to that, or no, you're not allergic to that, that's not what you get. What you get is whether it's a skin prick test with the size of the bump that comes up when you do the skin test, or with a blood test when it's the size of the number that comes back on the blood test, you're essentially getting something that relates to the likelihood that you're allergic. So the bigger the number is, the more likely it is that you're allergic, and the lower the number is, the less likely. And you have to put that together with the clinical history. Because if somebody says to me, "Do you know what? Every time I eat cashew nuts, within 5 minutes I get swollen and itchy." And if I did an allergy test on that person and it was a tiny little bump, I would still say that confirms your allergy because your history is absolutely clear and consistent and reliable. And all we need is some evidence that there is allergic antibody to that food. Where if somebody said to me, "I've eaten cashews 15 times in the last 6 months, every single time, nothing has happened. I enjoy eating large amounts of them, I'm absolutely fine." And then they did an allergy screening test and it came up with a little positive, which it absolutely might well do. That test is completely meaningless. It doesn't in any way suggest that that person's allergic. It just shows the limitation of the test. Because with all tests, they have a specificity, so their ability to sort of only identify real cases, and their sensitivity, their ability to identify all cases. And those things are not perfect. They're not 100%. So with all tests, you'll get a number of false positives, you'll get a number of false negatives. And what you have to do is interpret that test together with a clinical history and ideally a bit of experience at using those tests. If you went round to a nursery school and picked out 20 kids minding their own business, eating all sorts of things, you would pick up loads of positives if you started allergy testing them. And we see this happening in all sorts of clinics where people who aren't experienced at these tests, or online where people are able to get access to this test, cutting things out of their diet when they are absolutely clearly not allergic, but because they're misunderstanding what the tests are telling them. And then you get all sorts of people who have tests that are completely unrelated to allergy doing these tests and then saying, "I've just explained why I've been getting headaches for the last 6 years. It's because I've got an egg allergy." And they'll cut egg out and it'll make absolutely no difference whatsoever. But often they then won't introduce it again. And I often meet families where the kids are put on increasing restriction diets because of eczema that just needed to be treated conventionally and had absolutely nothing to do with food allergy. So a screening tests, they're a big no-go. However, when they're used in the right patients in the right way and interpreted appropriately in the context of the allergy history, they're extremely powerful tests.
I guess this ties in with a common misconception I see, particularly online, where people confuse and overlap allergies with intolerance. And obviously, the intolerance doesn't have anything to do with the immune system. Three-quarters of the world have a lactose intolerance. It doesn't mean they're allergic to lactose. And similarly, allergy, as we've described, has an immune system as its sort of core component. Similar to that example, is there any low-level or very kind of vague subclinical signs that someone might want to look out for to suggest that actually might be an allergy, instead of the common anaphylaxis where they get swollen lips or tongue and respiratory problems or even a big rash or hives? Is there something else which is like an unusual sign of an allergy that someone should just think, actually, maybe I could be allergic to so-and-so?
I would say not really, in the sense that with food allergy, particularly sort of classic food allergy, it's really not that subtle. It's something that will happen every time you eat a significant amount of that food. It's very consistent. As soon as people say to me, sometimes I can eat a load of this and I'm fine, but I've noticed that just on Wednesdays when I eat this, it's a problem. Immediately sort of thinking this really doesn't sound like it to be allergy. But the symptoms will usually be very obvious. They'll be immediate. They'll be around where the contact's been. So if you've eaten it, it'll be swollen lips and itchiness and issues right around where your mouth, whereas if it touched your skin somewhere else, it will be a local reaction there. And I spend more of my time, I think, trying to put people off from thinking, "Oh, it's allergy," as a reason when they have an unexplained symptom and it's not a typical allergy symptom. So I still get people coming to my clinic with chronic headaches and bloating and those sorts of things, where actually allergies are really, really unlikely explanation. So I would say, don't look too hard. In fact, I spend a lot of time trying to tell my patients not to look for trouble when it comes to allergy. Once kids have got one food allergy, there's sometimes a bit of a trap that the family will fall into, which is they sort of need to be proved to that a new food that their child's not eaten before is okay before they let their child eat it. So they want lots and lots of testing. So if they've had a reaction to lentils, for example, they'll say, well, we need to be tested for all of these different legumes, because how do we know otherwise that they're not going to react when they have it? And I always say to them, look, you have to take the other approach. Think back, your child is eating hundreds of foods that they don't react to, but there's one that they have. Really, the right approach is don't think it's going to be an allergic problem until you've had a reason to suspect it, until you've eaten the food and something's happened. Yes, it makes sense that if you've got an allergy to cashews, which are very, very closely related to pistachios, that we're going to do some testing and explore that a little bit rather than just say, we'll give it a go, because we know that most people will also react to that. But in those exceptions, that really a broader approach to life really should just be, just try it until there's a problem. Now, that might sound cavalier because you're saying, well, you're putting people at risk and they're going to have catastrophic reactions. Actually, if you look at the tiny number of very, very severe reactions that happen, it's extremely unusual for them to be to things that the person didn't know that they were allergic to. So what we don't tend to see is terrible reactions on the first time they've ever had a reaction to that food. So taking that view of saying, look, you've just got to stay out there and keep broadening your diet and keep eating as much stuff as possible isn't a cavalier approach. I think it's actually a very sensible approach, because it means that you end up with a much broader diet which protects you from developing other allergies, because regular exposure is a good way of developing tolerance.
Do you think there's any value in allergy testing, specifically when the parents of the child have specific allergies and might raise the risk of allergies in the offspring?
Interestingly, when you look at the studies that look at the, what risk does your family history give you, actually, the only reason that people who have got food allergies are more likely to have kids with food allergies is because they've probably had eczema when they were younger, which is why they got food allergies. And eczema is very genetic. And if their child's got eczema, their child's more likely to get food allergies. So if they've got a child who doesn't have eczema, their risk isn't really increased compared to anybody else. So when it comes to food allergy in small children, which is where most of the testing sort of, people are focused on, actually, I would be guided much more by whether that child has had significant eczema, especially if it started under the age of 1, in terms of whether there's value in testing, and much less focused on what the parents are allergic to. And the one thing I always have to remind parents is that you don't pass on specific allergies. So if dad's got a peanut allergy, it doesn't increase the infant's chance of having a peanut allergy. In fact, you could almost go the other way and say, look, if your family doesn't allow peanut in the house because dad's got, is very sensitive and will react if he's close to it, then if that infant is consequently growing up in a household where there's no peanut, they're actually at less risk of developing a peanut allergy, because where's their initial exposure to cause sensitization going to come from? So often the parent or an older sibling is sort of taking one for the team. As a result of their allergy, that's being excluded from the household, and they might well be protecting that infant.
I mean, my main interaction with allergies and medications comes in the hospital setting, where either before or after surgery, I might be prescribing medications or antibiotics to certain patients. And one of the common antibiotics that worldwide it's commonly prescribed is penicillin, or penicillin-based antibiotic. And you see so many people who have got a penicillin allergy. And actually, more often than not, they're not allergic to penicillin, but because it's on their record and we don't know when they were diagnosed with this supposed penicillin allergy, whether it's a real one, whether it's just some sort of side effect or interaction, if it's true allergy or not, we don't know. And then we have to prescribe them something else, another antibiotic, which may not be the most suitable for them. Why is this? I don't want to say myth, but why has this propagated so much that so many people are penicillin allergic and it's just permanently on their record, even when it might not be the case that it's a true allergy?
Huge issue. So when I first started my job at the Evelina Children's Hospital, we did a very quick and simple audit. We looked at every child admitted to the Children's Hospital to see how many of them were labelled as being penicillin allergic. It was 10%, very significant proportion. We then, and I remember it was 55 kids, we then really dug into their history. We did all the diagnostics required, and guess how many of them actually turned out to be allergic to penicillin? Just 10% of them. When we did our literature review and looked at other findings from similar studies, it was almost a universal finding across Europe, across Asia, the US, Australia. 90% of people who are labelled as penicillin allergic aren't allergic. And it doesn't take long when you start speaking to the people who have got these labels to understand where it's all come from, because the story is almost universally the same. And the story goes, when I was very little, i.e. before I can remember, so I need my parent to tell me the details. When I was little, I was given antibiotics because I had some sort of infection. And after the antibiotics started, I came out in a rash. So somebody put 2 and 2 together and got 5 and said, your rash is because of the penicillin. When, of course, we all know when you've got babies with infections, they come out in rashes all the time, and it's nothing to do with the antibiotics. Once that label's there, it's really hard to delabel them. And one of the reasons it's really challenging is that allergy testing, less so in adults, but in kids in particular, allergy testing for penicillin in kids is rubbish. Yeah, the kids who have got penicillin allergies, when you do skin tests or blood tests, they're negative. The kids who you test skin tests or blood tests and come up positive almost invariably turn out not to be allergic. So they have no predictive value and they're a waste of time. So there's actually only one useful test for antibiotic allergy in children, and that's giving them the antibiotic again when they're not unwell, to see whether anything happens. And as you can imagine, that's not a straightforward thing to organize all the time, and it requires a little bit of motivation on both sides. Now, I spend a lot of time in my clinic, what we call delabeling. So getting anyone who comes into my clinic and says, I'm allergic to penicillin, we get the story. We will usually bring them in, because it's usually not a very impressive story. We'll bring them in and we'll delabel them, because otherwise they will spend the rest of their life on suboptimal antibiotics. And the reason I really worry, and the reason that I think I always give that motivates parents to say, actually, we ought to sort this out, is, God forbid your child gets meningitis or septicemia or encephalitis and they're rushed into A&E. The first line antibiotics are all either penicillins or penicillin derivatives. And the best way to slow down that child getting the treatment they desperately need as quickly as possible is to start saying, I think my child might be allergic to penicillin, because then you rule out that whole class of antibiotics, you rule out all the cephalosporins, because we know there's cross-reactivity between them. And chances are it's complete bunkum. There's nothing there at all. So for that reason, I'm really, and there's a huge healthcare cost associated with this lifelong, because these babies will be 90-year-olds who are still telling their doctors that they're not, they have to have erythromycin or clarithromycin rather than penicillin when they get a minor infection. So the adults in the adult allergy clinics, they have big delabeling clinics. They're able to do intradermal tests, quite an unpleasant test where you inject a bit of penicillin under the skin, but that can be a useful and quite reliable test and save you having to do all those challenges. But it's really worthwhile doing, both in terms of the wider health economics of the NHS, but on an individual basis to make sure you've got an accurate diagnosis there. So you always have to view those labels with a bit of skepticism in the cold light of day. Of course, as a surgeon, as an anaesthetist, if someone says you're allergic, you have to take it on face value and assume, but it needs exploring afterwards sometimes.
You mentioned there about sort of cross-reactivity in regards to antibiotics, but also there's also cross-reactivity with various other medication and foods as well. And one common thing that I learned from an anaesthetist years ago were that there is some anesthetic medication which contain traces of shellfish, for example. And when a patient is in the hospital and they declare allergies, when they're doing the sort of initial admission test, some patients may not feel it's appropriate to mention food allergies when they're talking about allergies. And they just mention medication. Oh, I'm allergic to ibuprofen. I'm allergic to morphine, paracetamol, penicillin, etc. But they don't mention some of these vague, nebulous allergies, some food allergies. And I just really, that thing the anaesthetist told me about some medication having some crossover with, some shellfish really made me think about the importance of really disclosing the full list of allergies you got, no matter how relevant you think it is. Is that something that you've come across?
Yeah, so much as I spent yesterday morning struggling with our new electronic patient record at St Thomas's, even though we've had it for months on end. But one thing you've got to say about electronic patient records is that, once the allergy history is in there, it's really good at flagging it up all the time everywhere, because you have to do that, because there are some really bizarre cross-reactivities between certain medications, certain foods, anesthetic agents, etc. So it's really important to just make sure that you do that full disclosure every time, because it can come from the most random place. Vaccinations injections, for example. People with egg allergy can have real issues with the yellow fever vaccine, certain rabies vaccines, but not the MMR vaccine, even though most people with egg allergy will tell you that when they went to the GP, somebody didn't want to give them the MMR vaccine because they were worried about the egg allergy. And that's a very old concern that's not been borne out. Some of the flu jabs can have egg in as well, but most of them don't. So yeah, just being really open, knowing what your allergies are and telling everybody is a really good idea.
One thing you mentioned before, which I wanted to expand upon, was the idea of desensitizing yourself against an allergy. And I think it's probably has some cultural roots, particularly in East Asian cultures, where if someone is allergic to a certain food group, like say, for example, kiwi fruit, a common traditional remedy to cure that allergy, and I say cure in inverted quotes, would maybe be to either microdose that allergy persistently or even continually give that food almost as a form of pseudo exposure therapy to try and rid themselves of that allergy, like purging the allergy out of the system by overloading that person with the same food group or substance they're allergic to. Is there any molecule of truth in that at all, or is that actually just very harmful?
No. It's changed. It's turned the allergy world upside down in the last few years, particularly around food allergy. If you go back to the early 1900s, there's case reports in the Lancet of there's a child visiting a doctor on Harley Street that he wrote up with an egg allergy, where he put him through a successful course of desensitization by giving him small and increasing amounts. And in the early 1900s, in London at St Mary's in Paddington, the doctors there started giving injections of pollen to their severe hay fever sufferers. And that's gradually evolved into very effective, fully licensed treatments for desensitization for allergies to pollens and house dust mites, for example, for respiratory allergies. But the Holy Grail was more about desensitizing people for food allergies because of that risk of anaphylaxis that caused so much anxiety in these patients. And if we go back to about 25 years ago, people started to sort of, push the boundaries there. In the 1980s, there'd been some studies in the US where they'd applied what was then the current treatment for desensitizing for pollen, which was pollen injections, which occasionally could be quite dangerous. In fact, they sort of got banned in the UK between the 50s and the 80s. They used to be very popular because there was a number of deaths. But when they tried in the US in the 1980s to inject peanut allergic people with tiny bits of peanut, it did not go well. And so that sort of got completely shelved. But then people had the idea a little bit later. So researchers started giving people with food allergies tiny amounts of the food they're allergic to, and then gradually and really, really slowly building it up with very close medical supervision. This is one of these, do not try this at home. But that has developed into now we have NHS approved peanut desensitization products that do exactly that. They give you tiny but then gradually increasing amounts of peanut as a way of desensitizing. But we've got to be really clear what desensitizing means. It is not tolerance. It doesn't mean you're cured. You are still allergic, but it's a temporary state of being less sensitive. So you can get somebody with a peanut allergy and gradually get them to the point that they can eat a whole peanut without reacting, which massively reduces their risk of accidental exposures, because most accidents, when they happen because somebody's used the knife from the peanut butter in something else, or somebody hasn't washed a plate properly, or a little bit of peanut from the satay that was cooked in that Thai restaurant was still in the pan when the next meal got cooked in that pan. Those sorts of things very rarely go above that 300 milligram threshold. So if you can just get somebody to that really sort of, it doesn't feel very ambitious, but that low level of insensitivity or desensitization, you can dramatically reduce their risk of accidental reactions and make people feel much more confident eating out, traveling, having things that say may contains. It's absolutely transformational for families. And we can be increasingly ambitious, particularly in younger children, at the amount we're able to get them to tolerate. So this has completely changed my practice over the last sort of 5 years or so. It sort of feels sometimes it's mainly what I do is food desensitization. But it's only right for the right kids at the right time in the right way. It's not a panacea. It's not sort of, every child with food allergy should be being desensitized. For some families, the right way to manage it is to just carefully avoid it. And that's just the best way to deal with it. And for many families, they do that extremely well and very safely. And that's a great solution. But for many families, that has such an impact on quality of life, and it's so restrictive for them that they feel that life will be better if they go through what are risks, and there are risks of doing desensitizing treatment. You are putting the kid, in front of the allergen that they're allergic to. So you're going to get reactions to it. So you have to do a very careful process of shared decision making. Is this the right thing to put my child through a process that the end point will be beneficial, but carries some risks in the first place? And for some it is, and for some it isn't.
And you've mentioned that for food allergies. Is there something similar for pet allergies, for example? I know a lot of people around the world have furry animals, cats, dogs, and they are allergic to the hair or the saliva. Is there something that they can do so they don't have to get rid of their favorite animal and still be less allergic to them?
Yeah. So desensitization treatment actually is much safer and easier to do for environmental allergies. So pollen, dust mite, cats, dogs, things like that. It used to be injections. They did carry a risk. They weren't particularly pleasant. We've now moved much more towards what we call sublingual immunotherapy. So that's where the allergen, and that's all that's in the medicine. It's just the allergen that you're allergic to in huge concentrations goes under your tongue in either a tablet or a spray, and regular exposure to that produces blocking antibodies that get in the way of the allergic response. And as a consequence, you'll be less sensitive to it. Now, in truth, it's not really meant so that you can keep the dog that you're really allergic to. It's more that if you're really allergic to dogs, it's much easier that you can visit your friends who have got a dog and you'll have much less trouble and won't land up in A&E with a wheezy episode. But there are some families that still will take it to that extreme and will use it in that way. I mean, I think, around the world it's used in different ways, but it's got efficacy. I mean, there's value to these treatments. And actually with sublingual immunotherapy, it's very safe. And it's a home-based treatment. You really don't have to have much involvement with your doctor. Once that first dose has been safely given, something you can just get on with. So, yeah, there's huge potential to treat these allergens, and there's a lot of interest in developing what are called allergoids, so things that you mix up with the allergen so that it stimulates the immune system a little bit more, works more effectively, you don't have to take your doses quite so often. And then there's the fascinating world of biologics, which is just changing all of medicine, these new types of medicines that can hugely dampen down allergic responses. And it's looking like it's going to be a game changer in food allergy and other allergies as well. So a medicine called omalizumab, not even a new medicine, it's been around for asthma for 20 years. But if you've got multiple food allergies and you're on this medicine, in most cases, you'll find that your threshold before you actually have a reaction goes up quite significantly. But these medicines tend to be expensive. They need regular injections. But we can do short courses as a way of desensitizing a child to multiple food allergens at once, sort of with the air cover of being on this medicine that stops them from reacting to everything, so that you can very quickly get through what would otherwise be quite long and onerous courses of desensitization in pretty short periods of time. So suddenly making it dramatically more manageable. And then alongside that, we're starting to use those approaches, the sublingual approach we use for pollen, for food, because actually that can reduce the likelihood of having reactions to the desensitization. So much is going on, different ways of desensitizing. And suddenly in clinic, we've got all these options. I mean, before it was, you're just going to have to avoid it, cross your fingers and hope it goes away. And that was it. Very passive. We were just a diagnostic specialty. Suddenly in the last few years, we've become very much a therapeutic specialty. We can offer not just one, but a whole range of different options, carefully tailored to the individual needs of that specific child to really make life better for them from an allergy perspective. It's been a fantastic thing to be part of.
And for anyone listening at home who've got young children, particularly newborns, is there anything beyond what we've mentioned, apart from, really diversifying the diet? Are there any dietary strategies to help manipulate their future risk of atopic diseases?
I think that's tricky, because I think it's very easy to go off on some really unusual tangents that turn out not to be helpful. I mean, I always sort of say to patients, the really, really important thing is make sure you get a full diagnosis. I'm spending a lot of time on Instagram now, putting a lot of information out, basically just to try and manage the number of queries coming about these sorts of things. And I do posts about things you must ask your allergy doctor at your appointment, especially if you're not going to get much of a follow-up. Don't leave there until you've had, that conversation about what's the, how much risk is there? What's my emergency plan? What are the other things I might be at risk of reacting to? What are my other options for treatments? All of those is so important to nail all of those things down. For allergy prevention, when we talk to, pregnant mums, I think the bottom line is, doesn't really make that much difference what you eat during pregnancy and breastfeeding. Eating a lot of peanut or not much peanut just doesn't matter. But trying to have a really diverse diet that supports a healthy microbiome seems to be increasingly, we're recognizing, is going to be important. And then ideally trying to exclusively breastfeed and having exploring this idea of early introduction of allergenic foods particularly if there's significant eczema. And if your infant's got significant eczema, getting help and support around that eczema as early as possible, because increasingly we're recognizing that managing that eczema better can reduce the risk of those food allergies developing. So there's a whole range of things that are worth thinking about, but all of them come down to the same thing, which is going to be a really frustrating thing to say, because, and I'm sure you'll agree with me, if we had fabulous primary care that was responsive and you could get an appointment straight away and speak to somebody who really, really understands these issues, that would make a really big difference. And I think we've got a lot of work to do on public health around allergy, because that will consequently have a big impact on the rates of allergic disease. You look at Australia, they've just launched a huge national program that means that if you are diagnosed as an infant in any of the 10 big teaching hospitals in Australia, you will be immediately offered access to desensitisation for your peanut allergy. I mean, that's fantastic. That's so far ahead of where we are. And, it's going to be so exciting to watch what the outcome of that is. I mean, Australia's rates of peanut allergy are sky high. I mean, they overtook us some time ago as being sort of the allergy capital of the world, but they're really doing things about it. They've got really innovative joined up nationwide approaches. And I think that's something that we need to do better on here. I'm involved in something called the National Allergy Strategy through the National Allergy Strategy Group. That's a collaboration of the British Society for Allergy and Clinical Immunology and all the big allergy charities, Allergy UK, Anaphylaxis UK, the Natasha Allergy Research Foundation, all coming together to put together a strategy that we're doing it as far as we're able to with government agencies, but not endorsed by government agencies. But the plan is that the implementation will happen with government, because that's the only real way we're going to make a big difference through public health measures.
I think, when people hear the word allergy, they often don't appreciate the nuance of what an allergy is, what atopic diseases are, and actually what goes into forming an allergy. So, Adam, I really want to thank you for coming on today and just giving your expertise and, the academic science of allergies and how people can reduce their risk or, avoid increasing their risk. Thank you so much.
Pleasure. Thanks for having me.
Thanks again to Adam Fox. Did you learn anything new about allergies today? Or can you share any strategies you've used to manage yours effectively? Let me know in the comments. And make sure you subscribe so you don't miss the weekly Dr. Karan Explores podcast. And I'll see you oxygen smugglers next week.